ideal situation where you just have the faculty to talk to. So I'm going to talk to you on epidemiological studies in glaucoma bench to bedside, as Vinay named it, or as I may call it, creating a clinical translational enterprise. Comprehensive eye study, the Chennai glaucoma study, and the study that we did in Nagpur, the Central India Eye and Medical Study. So I'm going to take you give you some data about the prevalence of glaucoma from all the studies, but take you through the Central India Eye and Medical Study because I'm best able to tell you how the findings of this study help to translate into bedside clinical care. And I'm going to cut short on some slides so that I'm able to run through the, just emphasizing on the important slides actually. So basically we studied 4,711 subjects with a mean age of about 49 years from a rural part of central India, which was about 40 kilometers out of Nagpur. And we had a very detailed questionnaire that included the social demographic questionnaire, and because we wanted to especially find out what was the influence of other things, other habits of patients, and the dietary habits, the smoking habits, alcohol, etc. And we also did a clinical eye examination, which was reasonably detailed and included the normal routine examination, including a disc assessment, HRT, FDT, and macular photography. And glaucoma was defined by glaucomatous appearance of the optic disc, because we know that that's how we recognize glaucoma, and there are sufficient studies to indicate that the sensitivity and specificity of just looking at the optic disc to diagnose glaucoma is very high. And the optic nerve head was glaucomatous based on non-conformity to the Isn't rule, comparative thinning of the superior inferior rim to the temporal rim, or an abnormally large cup in a small disc in association with the appearance of the retinal nerve fiber layer. And this is what we thought was important in helping us diagnose glaucoma. So glaucoma was detected in 193 eyes, that's 2.18%, and it was unilateral in 51 patients, and it was bilateral in 71 actually. So in the open angle group, there were 108 subjects and 172 eyes, and the primary angle closure group, there were 14 subjects and 21 eyes. And so, surprisingly, the ratio of open angle glaucoma to angle closure glaucoma for subjects was 7.7:1. This is just the reverse of what the Velour eye study demonstrated, and maybe there is a lesson in this. The prevalence increased significantly with age, which is expected, and for the study population of 40 years and more, the prevalence of all glaucoma was about 3.45%, and it increased so that in the study population of 60 plus years, it was about 7.50%, and the implications of this is that if this were a hall full of eye specialists and they were 60 years and above, then at the least 7.5%, that is 7 or 8 people out of 100 would have definitive glaucoma, and there would be many other glaucoma suspects and many other patients who would have maybe primary angle closure suspect or primary angle closure. So that's the implication of this actually, and that is truly frightening for what it's telling us. When we did the multivariate analysis correlating the presence of glaucoma with other parameters, then what is important is lower body mass index came out as being somewhat significant. A lower level of hemoglobin was also significant, and of course higher intraocular pressure, disc hemorrhage, but higher mean blood pressure was also significant, and in addition, the presence of myopic retinopathy, longer axial length, lower level of education. So it's telling us that there is this matrix of parameters that when they come together, perhaps the risk will increase, and that taken alone also, they may have something to do with the development of glaucoma. And I think these are things that that can be translated into clinical care actually. What was really surprising and was that out of the 138 eyes with isgioglaucoma, that is when we used isgio criteria, and all of you either know about it or you can just take a look at what the criteria were, only 26 or just about 20% were considered to be glaucomatous with ophthalmoscopy. And that is a tremendous difference actually. And of the 193 eyes with ophthalmoscopic glaucoma, only about 15% eyes fulfill the ISGEO criteria. And therefore, when we go back, we need to figure out whether the ISGEO criteria are suitable for global translation into our clinics, or whether that is an extremely simplistic way of saying that if you have, so much percentile, and you fall beyond that, then we are going to say that you have glaucoma, and perhaps we need to come out of that era now, and we have enough evidence to say that maybe the way that we can, even just on clinical photographs, take a look at the optic disc, may be much more important than just going and using the ISGEO criteria actually. And these are the prevalence patterns that in the Central India Eye and Medical Study, over the age of 40, we had a prevalence of all glaucoma of 3.45%. In the Chennai glaucoma study, in the urban population, we had 3.51 for POAG and 0.88% for PACG. And the Chennai glaucoma study rural, we had 1.62% for POAG and 0.87%. And of course, these prevalence figures that you should have 3.51% for the urban study, and you should have only 1.62% for the rural study, that makes for extremely interesting reading. But of course, the most important thing was that the Chennai glaucoma study relied on ISGEO criteria to diagnose glaucoma, whereas we relied on ophthalmoscopic criteria. But nevertheless, the point is the difference between rural and urban prevalence, and that is something that we need to keep in mind actually. The urban comprehensive eye study was about 2.6% for all glaucoma included. The Andhra Pradesh eye disease study was about 2.56%, and angle closure there was about 1.08%, and the Vellore eye survey for those over 30 years and above was 0.41% actually. So there is a lot of variation, and I think it's got a lot to do with our own clinical expertise and how we diagnose glaucoma, but there are some interesting things that send us a message regarding the prevalence of glaucoma. And the ratio of open-angle glaucoma to angle closure glaucoma was 7.7:1 in our study. In the Chennai glaucoma studies was 4:1. Urban comprehensive study it was 3.4:1. In the Beijing eye study it was 2.6:1. But in the Singapore Malay eye study, it was 25:1 actually. And again, this makes for very interesting reading, that you might have thought that because you're a little bit east of India, then perhaps the ratio of open-angle glaucoma would be much less to the ratio of to the prevalence of angle closure glaucoma. But that was not the case. And again, I think that that perhaps there may be a greater need to validate what we consider as primary angle closure glaucoma to have an across-the-board uniformity, and that would certainly be helpful. But of course, what is really important to understand is that primary open-angle glaucoma is more common than primary angle closure glaucoma. So in conclusion, glaucoma prevalence in rural central India was determined, and glaucoma was associated, as I mentioned, with older age, lower body mass index, lower blood concentration of hemoglobin, high intraocular pressure, optic disc hemorrhage, and higher prevalence of myopic retinopathy and longer axial length. These were important parameters. How much time? I want to finish this in 10 minutes, and how much time did have I used up actually? No, just okay. I'll just give you 3 examples of what are the clinical implications, or how do we translate this. One of the first most important examples that came out was that the optic disc size was determined for the first time in India at 2.25 with the HRT actually, and the range was 1.12 to 4.61. And of course, we also came to know that the size of the optic disc in the community may be influenced by axial length, but this is completely another story. And we will recognize that the appearance of the optic disc is related only in a very different way with the axial length size actually. And the clinical importance of the optic disc size is something that all of you and No, actually, and this is the histogram of optic disc size from Central India Iron Medical Study. The second important clinical translation parameter was that the mean intraocular pressure was found to be 13.6 millimeters of mercury, so that we needn't have to rely on something that was done way back in Wales, in Britain, or in the Baltimore Eye Study, and now we have a mean intraocular pressure reading actually. So that was an important parameter. And then this third parameter was that there was a determination of relationship of intraocular pressure with the blood pressure, suggesting that the blood pressure may influence the intraocular pressure. And of course now it's not enough to just correlate the intraocular pressure with the blood pressure, because there is an issue of translaminar fibrosa pressure that has come in, and I think all three of them have some sort of role to play in glaucomatous nerve damage. And the fourth clinical translational parameter related to glaucoma was that we found the central corneal thickness to be about 514 microns, and I think that's very important. And as we know, the Chennai glaucoma study readings were also about the same, and this is of course important because even though in a mild variation going up or down, it may not influence the intraocular pressure measurement, but of course when the CCT is very high or much lower than the mean CCT, then we know that it does have an influence on the intraocular pressure measurement actually. So it demonstrates that clinical findings may have an impact on the assessment, diagnosis, treatment, and of course on the manpower planning, education, training, and resource allocation actually. And that's how we thought that there was a clinical translational value to all these population-based studies that have been mentioned in this study. Thank you all very much.